Personality disorders and behavioral disruptive disorders, aka everyone's cousin. Ha! We all have that one individual in our lives who shows up for holiday celebrations and makes it all about themselves. You know, we all know that one person. I'll let you think about it for a bit. Anyway, that's my insensitive introduction to a very serious topic. Um, Personality disorders, in particular, are, I think, the most complicated um, kind of category of disorders to fully understand because they can get a little bit confusing. I tried to make this presentation as streamlined as possible. The original presentation was like 70 slides, and I think I got it down to like 15. I just want you to have the clearest overview possible. Um, Typically, personality disorders are not a primary diagnosis in terms of the DSM. When you think about the axes of the DSM, you have axis 1, 2, 3, 4, and 5, with axis 1 being your primary diagnosis. Personality disorders tend to be your axis 2 diagnosis. So they're often along with something else that you might be experiencing, whether it be like schizophrenia, bipolar, depression, things like that, with a secondary diagnosis of the personality component. So let's get into it. I think this one will be a little bit quicker, but I am going to talk a little bit more during these slides because there are certain points I want you to focus on. So yeah, typically the personality disorders are usually categorized by behaviors and personality traits. They are not necessarily driven by some kind of disease process like schizophrenia or schizoaffective or bipolar might. However, they do show similar behaviors and traits that those diseases might show. So when we get into the different categories and classifications, I'll be able to better explain that. But for the sake of your learning, I want you to think about it as sets of behaviors and personality traits that differ from the social norm. So whether it be kind of odd or weird behaviors, whether it be like very anxious and socially needy behaviors and things like that, we'll get into it. How personalities develop. Um, I really want you to think about starting as early as possible in the human life cycle. So initially with like newborns and infants, moving all the way up to um, late childhood, adolescence, and then early adulthood. That's where most of the personality development will occur. And it usually is indicated by hitting developmental milestones. So when we think about Erickson's theory, we have like trust versus mistrust, and all that stuff. That's where kind of the initialization of the personality development happens. So if we really think about it, um, if you have a new baby, for example, and I'm mentioning that because I'm about to have a new baby, which is why I'm recording all these lectures. Um, if you if the parent is not as involved in addressing the baby's initial needs, so say for example, baby starts crying, baby's hungry, or baby wet the diaper, and parent doesn't immediately respond and address the baby's need, that's where we start missing the trust versus mistrust milestone. What that means is that the child is not developing a sense of trust with the parent to address their needs, which obviously can lead to issues down the road. Number one, secure versus insecure attachment. If baby does not trust that parent will meet their needs, they will need to have their needs met in other ways. And so, how does that usually manifest? Might be different types of behaviors. They're not going to hit specific milestones. And so they're going to start falling behind socially with other peers in their age groups. And this is really contingent on their environment. If you're raised in a very supportive environment with family members and your needs are being met and you have hit your trust versus mistrust milestone, you have secure attachment with the parents, then your behaviors are going to fall into that normal category of I can have my needs met by engaging in a way that is natural to me and natural to most other people as well. Um, if I'm hungry and I'm unable to be fed in a timely manner, what that might manifest as is louder screeching or finding different ways to get the attention that I need. And so as I grow up and I hit those different milestones in different age groups where now I have social skills and I am able to speak and engage in different ways and engage with my peers, the behaviors that I've learned as a baby to get my needs met are to act in a way that might not necessarily be the social norm. Um, so, attention seeking behaviors, engaging in different types of social activities that might garner more attention so you can have your needs met, engaging in different behaviors to have your needs met, things like that are where we start to see these personality issues pop up. Family dynamics, I have or lack thereof. If there's neglect happening and the child doesn't feel like they're having their needs met, that becomes a family dynamic issue. If an individual who is not the parent is able to meet the child's needs, then that can create difficulties in different relationship forming, because if I can get my needs met from grandma and not necessarily from mom, then that might kind of impact how I go about finding appropriate validation for my needs as an individual. I hope that is not too deep in the weeds for you, but I just want you to understand, like, this doesn't just pop up randomly. Like, it starts off very, very early, and personality disorders can be very challenging to care for, especially because they tend to be very difficult on nursing individuals who are kind of fulfilling the need of meeting an individual's needs, especially in the healthcare setting. And so projections of certain personality needs might be even worse to caregivers. So just an overview there. Again, bad environment, abuse, poor socialization. Kind of get the point here. Missing milestones is really the big one. If they don't hit trust versus mistrust, there's insecure attachments and things like that. We're going to start seeing these new behaviors start to emerge so the individual can have their needs met. Personality disorders are typically grouped by type. You'll see them called clusters. There are clusters A, B, and C. Each of the clusters has a very particular theme. We're going to get into it in the next couple slides just to give you a general idea of what they are. I'll tell you which ones you should focus on for testing purposes. Some are much more common than others. So cluster A, which is classified as the odd or eccentric category, these are going to look very similar to thought disorders. And I don't want you to get confused. Individuals who are experiencing cluster A personality disorders do not physically see hallucinations. They do not actively have delusions. They do not have the actual manifestations of schizophrenia or schizoaffective disorder, which can be a little bit confusing. So with paranoid personality, there is a notable distrust. They're suspicious of others. They have poor relationship forming. They don't necessarily develop strong loyalties to anyone, which is very similar to like paranoid schizophrenia, just minus the delusional thinking that might lead to that paranoia. The paranoia is just kind of there without the schizophrenia symptoms. So that's kind of a straightforward one to know. The more confusing ones are going to be schizoid versus schizotypal. And this is the best way to memorize it. Schizotypal is going to reflect as the positive symptoms of schizophrenia, whereas schizoid personality will reflect as the negative symptoms. So when we think of positive symptoms, we're thinking about those really odd outward behaviors. We're thinking about eccentricity, flight of ideas. We will not see audio-visual tactile hallucinations. That's just not something that will occur with the individual who is schizotypal. And then with the schizoid personality disorder, we're thinking about those negative symptoms. We're thinking about poor relationships, minimal sociality, anhedonia, alogia, things like that, where really the same categorization as those negative symptoms will start to show up. Again, they do not have schizophrenia. It's not driven by paranoid, delusional thinking or anything like that. They are just components of the personality. So again, schizotypal, positive, schizoid, negative. Um, if ever you were to be tested on these, I think it would be based on differentiation. That's why I'm kind of focusing on that. Um, Cluster B, dramatic, emotional, or erratic. These are going to be the more common ones that we associate with specific individuals. For either of them, um, focus on the actual presentations and the nursing needs. So, for antisocial personality disorder, typically it's reflected as having no remorse for actions, having issues with authority, being deceitful. Many of the known serial killers were diagnosed with antisocial personality disorder. So when we usually think of this, we think about young kids who are like physically abusive towards pets. And then that behavior starts to kind of build up over time and they start to kind of push boundaries. They might come off as very charming at first, but then they become very manipulative, specifically of people who are in a place of authority. So challenging to parents, challenging to teachers, challenging to police, where we start seeing that more serial killer type thinking come up. Is every person with antisocial personality disorder a serial killer? No, they are not. They do not always engage in violence, but we do start to see that no remorse for actions, being manipulative, and being deceitful. Then we get into borderline personality disorder. Borderline is one that gets mentioned a lot in healthcare because we often associate negative feelings or countertransference with these individuals. They are usually described as having instability, impulsivity, poor relationships. A lot of their behavior is based on identity disturbance and fear of abandonment. Oftentimes, this personality disorder will develop as a result of neglect as a child or abuse as a child. If I'm not able to have my needs met by my parent, I'm going to act out until I have my needs met. That's where we start seeing that self harm come up. Maybe if I start cutting myself, I'll be able to have my needs met. Maybe if I start burning myself, I'll be able to have my needs met. That's kind of the very, very basic overview of how borderline personality works. Um, Oftentimes, the identity will become the diagnosis. So we'll see, like, at least an experience that I've had working with this population, I've had a lot of experience working with it. If an individual starts to relate their identity to their diagnosis, it becomes more a matter of how far can I escalate the level of care that I'm receiving. So individuals who come in might start showing signs of self-harm. They might start making suicidal gestures and things like that. They will want to be on one-to-one constant observation. They might want to be restrained. They might engage in behaviors that lead to those outcomes happening for them. So we often see an escalation in behavior. We often see it at specific times as well, especially with fear of abandonment. I've seen a lot of NCLEX representation for this because borderline personality disorder diagnosed patients will often start to act out when they fear that they are going to be abandoned. And whether this be by family or whether it be by a healthcare provider, what you want to think about is when would I expect this person to start engaging in these unsafe behaviors? The number one answer is going to be either in transition of care or in discharge from inpatient level of care. Whereas you might see it as this person is now safe to go home, it's going to be better for them to leave. That's great and all, but if they're seeing it as, oh, this person no longer wants to take care of me, now I have to act in a way that will make them want to continue taking care of me, we will start to see those self-harm and suicidal behaviors start to emerge, especially as they approach discharge. So I want you to think about it that way because we're going to be prioritizing safety for these individuals. Then we get into histrionic personality disorder. That's your overly emotional responses, attention seeking, poor relationship boundaries. I always think about my extremely Italian father-in-law when he's kind of engaging during holidays. He's very emotional and he will cry very easily. If he's arguing with people, it will become very overdramatic. overdramatic. I feel like this is an Italian disorder, and I say that as an Italian. I always think about like the super overdramatic Italian dads. I don't know why. It's just like the culture I grew up in. And then narcissistic personality disorder. They have a need for admiration. They have to be the center of attention. They are very entitled. They really only care about themselves, at least in our perception. They have a very grandiose view of themselves. I am the greatest. I should be the leader. I should be this and that. You get the point. We all know one. Anyway, cluster C, anxious and fearful. So we have avoidant, dependent, and obsessive compulsive disorder. Um, don't get too in the weeds with the OCD component. I really want you to focus on OCD as the kind of anxiety related, not necessarily in this category, but it is here anyway. Avoidant, that is social inhibition, fear of criticism and rejection, just generally avoiding sociality, feeling inadequate in social settings. Dependent, we have need to be taken care of, fear of separation. This is another one that's very common in healthcare. People will come in and they expect to be taken care of as if they are a child. They will often exhibit like regressive behavior when they're in the hospital. So they are fully functional, but they still want a full bed bath, or they want you to assist with ADLs. This is really part of that dependent personality disorder. This describes my mom in a nutshell. She has to call me every day and share every single bit of information about her day, even if I'm in the middle of something or I'm busy. She just will not be able to go to sleep at night unless she shares all of her information about the day with me, and then likes to conspiratorially discuss things about other people, which is very fun. Seeking nurturance from others, attention seeking in that regard. And then for our obsessive compulsive, we have perfectionism, obviously, compulsive and obsessive thoughts, hoarding, things like that. All very straightforward. For testing purposes, the ones I want you to focus on are going to be schizoid, antisocial, borderline, histrionic, narcissistic, and dependent. I'm not going to go through it again, but just for the ones that are most common, the ones that I see the most, that's what I really want you to focus on. Meds do not work on personality disorders, so we do not often provide a primary pharmacological treatment. More often, we're using behavioral therapies and supportive therapies. So you'll see CBT, DBT, which are different types of behavioral therapies that help individuals kind of recenter their behaviors to better merge into society, basically. But my main point that I want you to take away is that they're not using meds to treat these. They will use PRNs if needed, but there is no medication that is specific to borderline personality, for example. So, in the event of a test question, you are not going to be advocating for a primary medication treatment. Nursing approaches. I stole this from ATI because I liked it. Clients who have cluster A personality disorders often have trouble relating to others. Be empathetic. Help client process emotions that they can't share with others. That's easier said than done, but it is something that we're thinking about because they're often not processing that information internally. So we're there to help them do that. Clients with cluster B disorders may find others shun their dramatic behaviors. The nurse will help them process their needs while setting boundaries. What this often translates to is you want to encourage and positively reinforce positive behaviors, and you do not want to enforce negative behaviors. What this often presents as is if they're exhibiting a negative behavior, advanced psychiatric care would often be to ignore it, even if there's a degree of unsafety happening. So if they throw themselves on the floor and you're in the middle of the hallway and they're in the middle of the floor, like I have seen individuals who are highly trained with cluster B personality disorder treatment to just walk over them. I've had individuals who were threatening to cut themselves or hang themselves, and I've seen highly trained individuals ask, like, okay, do you want me to watch you do that? Or like, are you gonna do it on your own? It's one of those things that would never appear on an NCLEX question. However, for individuals who have advanced treatment for these types of illnesses or advanced training for treatment, there are techniques that are used that are definitely different than you would expect, but they can be very effective as well. However, for you and for NCLEX training, if the individual is engaging in unsafe behavior, we're going to use the same processes that we always use. That's going to be evaluating for suicide ideation, using your resources to provide a one-to-one constant organization, and then if the individual is unsafe themselves or others, we might be considering restraints as well. And then for cluster C, we're thinking about decreasing anxiety, coping skills, empowering. Nothing too crazy, but this is a great slide in terms of just general ideas for the future. Priorities obviously are going to be safety, monitoring for suicide and self-harm, social safety, dangerous behaviors. Great select all that apply stuff. If you were ever to be studying a priority-based question, this would definitely be something I would consider for this lecture. Then we're briefly going to talk about disruptive behavior disorders. They're not as common in inpatient psych, but they do pop up and you will see them intermittently. I'm not going to focus too heavily on this, but for the sake of learning, they are a group of conditions. They usually present with poor impulse control, some aggression, disruption, poor self-control of emotions, etc. You often see this with the adolescent population. And when I talk about adolescent care, I often say, like, if you ever work on an adolescent unit, it's basically a license to have a fight every single day because they tend to be relatively dangerous units to work on in terms of behavioral control. And it's often because of these types of diagnoses where we start to see that aggressive outward behavior, not having any impulse control, learning from childhood that if you act out dangerously, you'll get the attention and have your needs met. So we often are able to see these manifest in an adolescent unit when they now have the physical capacity to do some serious harm. And so we're thinking about treatment parameters here that keep everyone safe ultimately. So we see things like impulse control disorder, oppositional defiant disorder, which we'll talk about a little bit more, kleptomania, which is stealing or shoplifting, pyromania, which is setting things on fire. Just a general idea of what these typically look like. So we initially see them in children. And what they usually say when they're in like the pediatric phase is like, oh, this is just their temperament. Oh, they just act this way and they'll grow out of it. But what it really translates to is are these different types of diagnoses. They do require behavioral therapy, just like with the personality disorders. They do not have specific meds that treat them. You might use PRNs to address relevant symptoms, but there is no pharmacological treatment that you would use to treat these types of disorders. I will provide a document regarding the individual breakdown of each of these, but I don't really want you to focus too much of your effort on them. What I really want you to focus on are the personality disorders. And then when you guys get into pediatrics, you'll start to see more of the behavioral stuff pop up. So I don't want to overdo the pediatric stuff right away because you're going to see it again. It'll make more sense when you are going through lifespan development and pediatric nursing care. But that's all. I hope you have a good rest of your day.